Today we are going to talk about management of carcinoma stomach. If one goes into details, the presentations of patients are so varied, it is difficult to talk about every situation. They have n number of combinations or permutations in presentation. Therefore, to talk about a situation becomes difficult. Only principles can be talked about. Last time while talking about histology, I forgot about mentioning grading of a tumor. The grading, the carcinoma stomach is graded into three: well differentiated, moderately differentiated, and undifferentiated. This is based on ability of malignant cells to form gastric tubules. Better they are formed, more differentiated they are. No attempt at formation of tubule at all, haphazard cells, is undifferentiated, and they are prognostically very important. Molecular biology of carcinoma stomach is being studied. MicroRNA, which controls the gene behavior, and a gene in turn controls the cell division, cellular invasiveness, and capacity to metastasize. Based on this, they have created genomes. There is an atlas. They have divided into 4 subgroups. The studies are going on to find out a drug which targets a malignant cell, leaving behind a normal cell completely untouched, unlike chemotherapy. Chemotherapy does have an effect on malignant cells, but it also has effects on normal cells also. That is a limitation of chemotherapy. We are migrating towards targeted cell therapy. Today it's in infancy. How long will it take, God alone knows. But if this gets added, I mean, there are already trials of few drugs are being used, but their evaluation is still not complete. When we talk of management, there are 3 methods of treating carcinoma stomach. Number 1 is surgery. Number 2 is chemotherapy, and number 3 is radiation. Out of this, surgery is the only curative therapy. No other treatment is curative. Therefore, people talking about surgery and describing surgery in various forms is tremendous. Surgery aims at R0 resection. What does R0 resection means? R means no residual tumor. That is the aim. At least macroscopically, the aim is to remove the entire tumor. Microscopically, this may not be possible. The types of surgery which are done, number 1 is, this especially in Japan, very early cancers which come in stage 1 or rather T1, T2, where the tumor is localized only to mucosa and submucosa. In Japan, this is I wouldn't say common, but fair number of patients are seen in this group. But in other parts of the world, there are accidents. To get a patient who is just T1, T2 tumor localized to mucosa and submucosa, not crossing the muscular layer, it has a size less than 2 centimeters. Here, gastroscopic excision of the ulcer is done. The margins must be at least minimum centimeter more around the tumor. After excision, the material is sent for histology and a detailed examination to find out that the excision is complete with microscopic no malignant cell. The completeness of resection is very important. Another, apart from being rare in other parts of the world, this needs regular surveillance by gastroscopy every 6 months for at least 5 years. This is one of the treatments which has come recently. with gadgets being available. The second surgery is gastrectomy. Based on the site of tumor, if the tumor is upper part of the stomach, you call it upper total radical gastrectomy, where entire stomach is removed and the anastomosis or the continuity of GI tract is maintained by taking a loop of jejunum to the esophagus in a roux-y fashion. The second is when the tumor is in the lower part, which is so in majority of the cases, more than 60%, 70% are in the lower part of the stomach. The type of gastrectomy is called as subtotal radical gastrectomy. In total gastrectomy, entire stomach is removed. You close the duodenum and take a loop of jejunum up in the esophagus. In a lower radical gastrectomy, the duodenum is closed. You remove the entire stomach, most of the stomach, leaving behind a gastric pouch of fundus and a small part of stomach. The rest of the stomach is out. The continuity of GI tract is maintained by gastrojejunostomy. The third type of surgery is called as partial gastrectomy. Partial gastrectomy is more a palliative operation. It is not included in R0 resections of stomach. As far as lymph nodes are concerned, there is D1 type of lymph nodal resection and D2. D1 stands for the number of lymph nodes, the group of lymph nodes we should remove. D1 lymph nodal resection is lymph nodes around the stomach, right gastric, left gastric, prepyloric, right gastroepiploic, left gastroepiploic, and lymph nodes on the cardiac stomach. Here you remove the greater omentum, the gastrocolic omentum, lesser omentum with these lymph nodes. To say that D1 resection was complete, the resected specimen must show more than 15 lymph nodes for it to be categorized. D2 resections are extensive. They not only go beyond the regional lymph nodes, involve the entire lymph nodes along the free edge of the lesser omentum, right up to high level of liver. They remove the lymph nodes along the superior inferior border of pancreas. They remove the lymph nodes along the splenic pedicle right up to the pedicle enters the spleen. They also remove the lymph nodes from esophagus down, paraesophageal, preesophageal lymph nodes in the stomach, entire lesser omentum, and lymph nodes around the celiac axis also. In this operation, whether spleen should be removed or not, whether distal pancreas should be removed or not, to complete the resection is doubtful. Some people do it, especially in Japan. Some people do not touch them, they just remove the lymph nodes. For these operations to be done, apart from the fact that the disease must be within the stomach, but the general condition of patient must permit it. Here the comorbidities and age of the patient is very important, otherwise the mortality jumps. When we talk of R0 resections, gastrectomy plus lymph node resections, we always talk of macroscopic destruction or removal of disease, not microscopic. Some of them in early stages, microscopic R0 resections are feasible. In many of them, R0 resections macroscopically are feasible, but microscopically are not. As far as removal of other parts of the stomach, you find dedicated centers which are meant for treating this. There are very few contraindications for removal of stomach. Omentum and any part of GI tract which is around the stomach, which can be removed, like transverse colon, like gallbladder, attachment to spleen, body pancreas, that does not make a patient inoperable. They have done such extensive resection, even these parts are removed. It is needless to say that it is macroscopic R0 resection, not microscopic. Partial gastrectomy. Partial gastrectomy is done when we talk of complications, when we talk about it. The partial gastrectomy sometimes is done to reduce the tumor load in a patient who otherwise have fair general condition, but has no other problem. We know this has a small metastasis in the lung or a small metastasis in the liver, but general condition is okay, but locally to remove the tumor load so that chemotherapy or other supportive methods act more aggressively. Such partial gastrectomies are done. They are palliative. You don't expect a tremendous result. You don't expect a 5-year survival rate also. When a patient presents to you, you take a decision. At the end of investigations, whatever are available, first for diagnosis, establishment of histological diagnosis is first, which is gastroduodenoscopy and biopsy. The second is, this we talked last time, the second is to find out the stage of disease, what has been involved. Based on this, sometimes even clinically, Blammer's shelf, cysticercosis nodular umbilicus, hard nodule liver, malignant ascites, malignant pleural effusion, present clinically makes a patient inoperable. These patients straight go for palliative treatment. There is no question of surgery or curative treatment. Some of them, from a patient who looked to have a localized disease, after investigation converts itself into inoperable. Such inoperable patients are treated by chemotherapy and radiotherapy. Chemotherapy came a little later in the management of stomach. Initial chemotherapy was adjuvant chemotherapy. After surgery, they would place a patient on chemotherapy. This had almost become a routine. But now it is neoadjuvant chemotherapy. Prior to surgery, chemotherapy is supposed to have advantages. Number one, it downgrades the tumor. It destroys the microscopic metastasis. And you can do a relook laparoscopy to find out what was the effect of your chemotherapy. This is especially so in stage 3 and stage 4 tumors. Therefore, today's trend is T1 N0 tumors are not given chemotherapy. They are supposed to have complete R0 resection satisfying, macroscopic as well as microscopic. T2 or stage 2 tumors have adjuvant chemotherapy, but stage 3 and stage 4 get a new adjuvant chemotherapy to downgrade a tumor and find out whether R0 resection is possible or not. So, after the end of neoadjuvant chemotherapy, we need to reassess a patient by investigation to find out whether R0 resection is feasible or not. Radiation, some centers give radiation. Radiation also has advanced, has become more targeted. But radiation is not used universally in carcinoma stomach because radiation has effect on intestine, radiation has effect on pancreas, radiation has effect on liver, radiation. Therefore, radiation, however targeted it may be, has a limited value. But in inoperable cases where the tumor is large, fixed, people have tried chemo and radiation together. The third presentation is in emergency with complications. Number one complication is tumors at the upper end of stomach presenting with dysphagia, tumors at the lower end of stomach presenting with vomiting, pyloric obstruction. If the case is operable, you go ahead. If the case is inoperable, for esophagus, they core out the center of tumor, create a space so that swallowing is maintained. The obvious disadvantages, it is very short-lived. But the advantage is patient has a sense of swallowing and therefore satiety. Much better than feeding jejunostomy, which is another alternative. In pyloric obstruction, this is a place where if the tumor is locally resectable, not fixed to any important structure, you do a partial gastrectomy. If the tumor is locally invading pancreas or head of the pancreas and that bile duct, then it is better to do a gastrojejunostomy, bypass the obstruction. Then even these mild procedures have a mortality, not only because patient is very old, has usually comorbidities and has suffered because of, for a long time, because of malignancy. When we talk of second complication is bleeding, the benign malignant gall's ulcers are known to bleed. The incidence is very low, but it does happen. This is confirmed after gastrojejunoscopy. You know what is bleeding, what kind of bleeding, which vessel, is there a major hose or is it a ooze? Based on that, most of the times, the gastroscopic maneuvers like heat probe and clips don't work in malignancy. If the tumor is locally resectable, the operation of choice is partial gastrectomy. This is especially true for lower cancers than upper cancer. Upper cancers make it very difficult. Mortality is very high. The second complication is perforation. The perforations, gastric perforations as such have a higher mortality than duodenal perforation. This we talked last time. Gastric malignant perforations are terrible. The diagnosis is made by, if a diagnosis is, if gastrojejunoscopy was not done and you face a perforation, we talked of when we talked of gastric ulcer, here closure of perforation and very good biopsy is essential. But when we know it's a malignant ulcer which is perforating, you have to go in and close the perforation. Sometimes the ulcer is small, you excise the ulcer and suture it. Sometimes it ends up in partial gastrectomy also, provided it was locally resectable. Sometimes you just end up in closure of a perforation. Needless to say, in all these complications, the mortality is very high. When we talk of prognosis of carcinoma, the factors which affect prognosis are age. I mean, common sense. If the age is high, the prognosis is worse. Sex, slightly better in females than in males, because possibly comorbidities are less in females as compared to males. Number 3 is staging. The most important factor is staging. Number 4 is, of course, the type of operation, type of resection you carried out. Number 5 is associated comorbidities. Number 6 is grading. Number 7 is size of tumor. For the, even if it is T1, I'm talking about, say, if I take a specific example, polypoid tumor. Polypoid tumor are exophytic, they don't tend to infiltrate into the stomach wall. The infiltration might be minimal, but if the tumor is 3 centimeters, the tumor is 6 centimeters, the 3 centimeter tumor will have much better prognosis than 6 centimeters. I had to explain this what I mean by size of a tumor. Why should size affect the treatment? The size affects treatment when staging is same, but the tumor is larger, it definitely brings down the prognosis. In Japan, fantastic. The overall rate of R0 resections are almost 75 to 80%. They take malignancy so early, and therefore their 5-year survivals are also 60 to 65%. The rest of the world, the 5-year survival now is about 25% to 30%. United States, Sloan Kettering Institute quoted that prior to institution of chemotherapy, if I have a survival of carcinoma just 15%. After neoadjuvant and adjuvant chemotherapy was added, the rate has gone up to about 25 to 30%. It still remains a very ghastly tumor. The problem is stomach must learn to react to its own malignancy rather than reacting to pregnancy or cerebral concussion. I hope I have done justice to the topic. Thank you.